Hey guys, this is Dr. Aman Setiya from DBMCI. So today we'll discuss INI-CET Recall Questions. So the paper was a bit tricky, but most of the questions they came straight away from your class notes. So just try to understand the pattern. So they are just trying to make the topics little complicated, but concept was still the same. So there were a few repeat questions as well in exam. So one by one, let us see the questions. Okay, there may be some variation in the question because these are the recall questions. There may be some difference in the options. So if you find any difference, you can text in the comment box whatever difference. We will try to revert your answers. So starting with the first one. So let me see this question. A patient present with proximal muscle weakness. So this is the main hint. Whenever you see this proximal muscle weakness, facial rash and following image. So now understand this, in this question we can see proximal muscle weakness. So this could be a case of dermatomyositis. Or it could be polymyositis. These are two myositis which will have proximal muscle weakness. Now understand this, if I say polymyositis has been ruled out because there is no skin changes here. Then if I talk about SLE, you can see the classical we can see butterfly rash, Muller rash. So there is no such rash is given. I could not get the fourth option. Let me suppose the fourth option could be scleroderma. Then they could have given the patient can have sclerodactyly, that is absence of folds in the back of finger. These folds may be absent. So here in this image you can see, let me zoom this for you, you can see these papules. So this papular rash is classical rash. What we call this? We call this as gout-round papules. Gout-round papules. So this gout-round papules along with the very classical hint in exam is proximal muscle weakness. These two are important enough to make a diagnosis. That is, diagnosis for this condition will be dermatomyositis. Okay, so to tell you furthermore, like there is also a type of myositis, we call this inclusion body myositis. That inclusion body myositis will have a distal muscle weakness, and that is seen in old people. These two conditions, these are seen in young people. So answer for this question will be dermatomyositis. Okay, next question. This is again an easy question. Rejection of which of the following result in macrocytosis? Macrocytosis means they are talking about macrocytic anemia. So macrocytic anemia you can see in B12 deficiency, you can see in B9 deficiency, you can see in liver disease, and you can see in some thyroid disease. So these are four important causes which you have to remember. So again, this is these are like they have not asked you a single medicine question. They are they are integrating the session, integrating the topics. So this is like a physiology overlap with medicine. So now you should know the site of absorption of each of these things. Like if I say B12, B12 is absorbed where? This is absorbed in ileum. So absorption site you have to remember. B12 absorption site will be ileum. So ileum rejection can cause macrocytic anemia. So this is ruled out. Coming to B9, B9 is a folic acid. This folic acid is absorbed, or I can say the absorption site of folic acid will be in duodenum and majority in the jejunum. So means in jejunum and duodenum both. So mainly I'm writing here jejunum. So jejunum is the site. So that can also cause. Then if I talk about iron is primarily absorbed in duodenum. So main site of folic acid absorption is jejunum. If I talk about iron is absorbed in duodenum. Now if I talk about stomach, like this B12 is carried. So duodenum is the site for iron. This B12 is taken care by intrinsic factor. This intrinsic factor will take B12 where? This will take B12 to the terminal portion of ileum, and here what we have receptors. These receptors are called tubulin receptors, and ultimately B12 is absorbed in ileum. Now from where we have this intrinsic factor? Remember, this intrinsic factor is produced from where? This is produced from parietal cells, and which are located in stomach. So suppose if you have rejected the stomach, then there is no intrinsic factor. No intrinsic factor means there is no one to take B12 for absorption site, right? So just understand this. This is like pernicious anemia. If it is antibody against intrinsic factor, we call this pernicious anemia. So that is a type of megaloblastic anemia that can lead to macrocytosis. So understand this. Ileum is a site of B12 absorption. So that is not the answer. If you see jejunum, so ileum rejection can cause macrocytosis because there will be B12 deficiency here. Jejunum rejection, there can be B9 deficiency. Stomach rejection, that can also cause B12 deficiency because there will be no intrinsic factor. On the other hand, so after ruling out all these choices, I have duodenum as the main answer. So duodenum, if you reject the duodenum, the patient will develop mainly iron deficiency, not macros. Iron deficiency is microcytic anemia. Clear? So answer for this question will be duodenum. Okay, then this was the question. What is the diagnosis in given ECG? So let us first see this ECG. What you can see by looking at this ECG, the first thing which will come in my brain will be this is, you can see, P wave. So let me first label the P wave. This is I can say P wave. So I can draw this as P wave. Then we have QRS T. Then we have P wave, QRS T, P wave, QRS T, P wave. Then what you can see here something. What we call this? We call this missed beat. So we call this missed beat, or I can say drop beat. Missed beat or drop beat. So whenever we see missed beat or drop beat, so that is a feature of second degree AV block. So then we can see the PR interval. You can see this is the PR interval. So if you see the PR interval, this PR interval is prolonged. So now let's see the option. So by looking at the ECG, you will get an answer. Now if you see sinus bradycardia, so here you will see a bradycardia, but every P will be followed by QRS, so that is not the answer. In first degree AV block, you will see no missed beat. You will see PR interval is prolonged, but there is no missed beat. So missed beat is not seen. In third degree AV block, you will see AV dissociation. AV dissociation means atria and ventricles, they move separately. So atrias, they are moving at a separate rate and ventricles are moving at a separate rate. So what we get? We get here a constant PP and constant RR interval. So we call this AV dissociation. So understand this. After ruling out all your choices, so we can see a drop beat. So this is a second degree AV block. Like some students are telling Mobitz 1 was given, some are saying Mobitz 2 was given the option. So whatever it is, but remember both are type of second degree AV block. So you can see here there is progressively increase in PR interval with the drop beat. So this is again an easy question, easy ECG. So what is my opinion in exam? The major chunk of medicine part was given from neurology, cardiology, and there was some question on hematology. So these three were the main topics which was asked in exam. However, there were less question on nephrology, respiratory system, but most of the question they asked, that was from cardiology, neurology. So these are two very, very important topics which you have to study in detail. Okay, which of the following drug is given prior to thyroid surgery to decrease blood loss during surgery? So like again, this is an easy question. So before thyroid surgery, what we give? Before thyroid surgery, you can see we give potassium iodide or Lugol's iodine. Lugol's iodine or potassium iodide, this we give to prevent a dangerous complication like thyroid storm. So steroid we don't give. Propyl thiouracil methimazole we give in management of hyperthyroidism, but not to prevent the or the prophylactic measures. So answer for this question is straightforward, easy one, that is potassium iodide. Potassium iodide or Lugol solution we give to prevent a thyroid storm or bleeding complications during thyroid surgery. That's very, very important thing. Okay, coming to next MCQ, which of the following benzodiazepine is preferred in liver failure patient with altered liver enzymes? So this was like some students said, it was given in patient with seizures. In patient with seizures with altered liver, this thing was mentioned. So understand this. Whenever you some are also saying like it was given an alcoholic patient. So whatever it's given, so understand this. Normally what we prefer when alcoholic patient is having for alcohol withdrawal, also for seizure we can give benzodiazepines. So benzodiazepines, these are sedative drugs. So in alcoholics we prefer chlordiazepoxide. chlordiazepoxide, this is the longest acting benzodiazepine that we preferred. But any person who is having hepatotoxicity or some, because alcohol will also cause liver damage, it can cause alcohol hepatitis or cirrhosis. In that case, we avoid this. In that case, what we prefer to give lorazepam, and a more better drug what we have nowadays, what we give oxazepam. So oxazepam is the preferred drug that we give in a patient. So diazepam, again midazolam, alprazolam, these are like this. If I say alprazolam, midazolam, these are short acting and they can also cause liver damage. Same with diazepam, this cause liver damage. Oxazepam will not cause, so that is why we preferred oxazepam in this patient. Coming to next question, which is not a sign of heart failure. So like we have different guidelines, like we have American Heart Association, right? We have ESIC, we have many other guidelines, we have WHO guidelines. So we know some sign and symptom of heart failure. So let me see this question, non-pulsatile rise in JVP. So whenever you see a patient, especially right side of heart is involved, then you will see JVP rise, and that JVP rise is pulsatile. So let me keep this option in my brain. Dyspnea, orthopnea, PND. PND means paroxysmal nocturnal dyspnea. So this is shortness of breath after 2-3 hours. This is nothing. This is PND. So dyspnea, orthopnea, I can say then paroxysmal nocturnal dyspnea. These are the symptoms that patient have. Right hypochondrial pain. So some patients, they have right hypochondrial pain. Why? That is because these patients, what they have congestive hepatomegaly. So there is tender or congestive hepatomegaly that is leading to right hypochondrial pain. So let me see what I taught you. You can see the patient can have fatigue. There can be dyspnea on exertion, which is more specific. There can be orthopnea, tripopnea, bandopnea, platypnea. These all are types of dyspnea. So there can be orthopnea. There is PND, there is edema, palpitation. There is increase in JVP. There is congestive hepatomegaly. This congestive hepatomegaly or tender hepatomegaly, that is producing a right hypochondrial pain. There can be hypotension, edema, there can be gallop rhythm. So these are the symptoms and signs to make a diagnosis. We should have minimum 2 symptom and minimum 2 sign and 2 symptom. So after, you can see here, this is like orthopnea. We can consider this as a variant of dyspnea. So this is seen, this is seen, this is seen. You will see pulsatile rise in JVP. Non-pulsatile rise is not a sign. Non-pulsatile rise in JVP, this is seen in any person with SVC obstruction, but this is not seen in a patient of heart failure. So I repeat, in heart failure you will see pulsatile rise in JVP. So by ruling out other choice, the answer will be A. Okay, there was a question on memantine. So however, I could not get the exact question. So memantine, as you know, this is the drug that we use in patient of Alzheimer's disease. So in Alzheimer's disease, we can use drugs like donepezil. We can use memantine. We can use rivastigmine, donepezil, memantine, rivastigmine. Then we can also use galantamine. So you can write in the comment box what was the exact question, but what I could get, there was a question on Alzheimer's disease and memantine. Okay, then this was a question which is not seen in aspergillosis. Again, a question which is very I can say difficult type, one of the difficult question in exam, because in aspergillosis we see all these things. We can see cavitation because there can be pneumonia, there can be cavity formation due to aspergillosis, so cavity formation is seen. There can be ground glass opacity in later cases. There can be ground glass opacity in later cases, or in person who is having a long aspergilloma. So in aspergillosis we can see GGO, we can see consolidation. Consolidation you can see in numerous disease, and aspergillosis is one of the fungal infection where we can see consolidation. So again, these three are seen, but remember what is less seen is, so actual question should be framed like this: which of the following is less seen? So that should be the ideal question in my opinion. So if I say the less seen thing here is pleural effusion, this is seen in very, very few patients. So answer for this question will be, after again ruling out that is pleural effusion. So what I understood with this paper is you should practice more and more MCQ so that your brain start working. You should think, your neurons should be firing at a deeper level. You should think more, because this time they are relating biochemistry, microbiology, pathology, pharmacology, everything with medicine. Okay, then this was an easy one, easy question straight away from the notes, that is cerebral perfusion pressure. So if you see cerebral perfusion pressure, this is difference of MAP minus ICP. So this was the easy one. So CPP, that is MAP minus ICP. So this is the easy question. I think all of you made this correct. This is cerebral perfusion pressure. Okay, so this is a question. You can see, name the culprit vessel. This is a topic like whether it's INI-CET or NEET PG or FMG exam. This is the examiner's favorite topic. They used to ask this this type of CT they ask a lot. So I have seen like almost at least in one exam in a year they will ask this question. So this is one of the favorite topic of examiner. So you can see this first thing is white. This white is blood. And if you see the shape is concave or convex, or we call this crescent shape or semilunar shape. So this is like I can say SDH, subdural hemorrhage. And subdural hemorrhage, remember, this is due to a venous bleed, and these veins are called bridging vein or vortex vein or emissary vein. So this is bridging vein. So diagnosis for this case is SDH. So we have discussed this in detail. So you can see ADH, you will see middle meningeal artery bleed, then we can have SDH, that is your vortex or emissary vein. You can see the shape lenticular, you can see here concave or convex or semilunar or crescent shape. In SH you can see bleeding near Sylvian fissure. So this is like a straightforward question. A radiology again overlap with medicine. So culprit vessel in this condition will be bridging vein. INI-CET aims PGI, they used to ask a question from the disease which is trending, or disease which was trending in past 1 year. So like when there was a COVID time, we have finished the COVID. After COVID, there were many cases of mucormycosis. There was many cases of scrub typhus as well. So scrub typhus was a trending topic, and I told this information in one of my live class, like this is a topic, hot topic. They can ask you this question, and the question came in exam. So you can see here, this is scrub typhus is chart. So suppose if I don't know the question, because this is dermatology overlap with medicine, so let us solve this one by one. Rocky mounted spotted fever, you will see multiple spots in the skin. So single lesion on this type of deep lesion is not seen. If you talk about COVID-19, so COVID-19 can cause many things. So no specific dermatological finding we see in COVID-19 by far till now, so that is ruled out. If you talk about dengue causes more a facial rash, that you can see some hyperpigmented deep rash in the area of the nose, in the cheeks. Or dengue can cause a rash where that is a purpuric rash in the skin. This rash will be like a small bleeding or a small petechial rash. We call this island of white in sea of red. So these are small petechial rash that we see, can be multiple small petechial. So dengue you will see, or you can see this will be small petechial rashes. Then you can see in dengue, this is first rash. Second rash you can see in dengue will be a deep facial rash. This S-char however is not seen. This S-char is classical for scrub typhus, which is caused by Orencia Susugamushi. We also call this Susugamushi fever. This is a rickettsial disease. Okay, this is like I can say Susugamushi. Orencia Susugamushi, which is a rickettsial disease, right? And this is the mite-borne disease. Incorrect statement about hemophilia. So let us see this question. Hemophilia. So I think this is like typed by mistake. It was given X-linked recessive. So what is the incorrect statement? So let's solve this question. So we have 3 types of hemophilia. We can have hemophilia A, there can be hemophilia B, and there can be hemophilia C. Hemophilia A is factor 8 deficiency. This hemophilia B is factor 9 deficiency. Hemophilia C is factor 11 deficiency. So you can see these three different type of hemophilia A, B, C. This hemophilia A is called classical hemophilia, B is called Christmas disease. Now understand these all the hemophilias, I can say in all hemophilias, first common point is these are clotting factor disorder. These are clotting factor disorder, right? Second thing is clotting factor means they mainly involve, like in clotting cascade we have extrinsic pathway, intrinsic pathway. So these are involving your intrinsic pathway. These are involving your intrinsic pathway. So whenever you will see intrinsic pathways involved, what we can notice? We can notice APTT. APTT will increase. PT or INR will be normal. Prothrombin time or INR will be normal. APTT is increased. So if you talk about hemostasis means we can divide hemostasis disorder into disorder of primary hemostasis and secondary hemostasis. So primary hemostasis means whenever there is a bleeding, the first cell that will try to stop the bleed is platelet. So primary hemostasis means this is done by a platelet. And secondary hemostasis, suppose this whenever there is a bleeding, you will see first platelet will come and they will try to stop the bleed. That is called primary hemostasis. So they will form a weak platelet plug. They will form a weak platelet plug. And this weak platelet plug is vulnerable to rupture. This may rupture again. This may rupture. So this to provide some stability to this, we need clotting factor, and that is called secondary hemostasis. Secondary hemostasis is it is done by clotting factors. So I repeat, primary hemostasis, this is done by platelets. Secondary hemostasis is done by clotting factor. So primary hemostasis, this will make a weak platelet plug. To make this strong, what we need? Secondary hemostasis. So disorder of primary hemostasis, we have diseases like Bernard-Solier syndrome, Glanzmann thrombocythemia, we have ITP, TTP. In secondary hemostasis, we have clotting factor disorder. Then remember, any condition which is a defect of secondary hemostasis, this will present with bleeding in the muscle or in the joint. So there will be joint or muscle bleed. Like patient can develop, example I can say there can be hemarthrosis. But if I talk about this platelet bleeding, a platelet disorder of primary hemostasis, you can see this will present with bleeding on the mucosal bleed. This can present with mucosal bleed, right? Or sometimes there can be a rash in the skin. So understand this hemophilia, this is an X-linked recessive condition. That is why this affect boys. So it's an X-linked recessive condition, so boys are affected. It is deficiency of factor 8, true. This is not a disorder of primary hemostasis, it's a disorder of secondary hemostasis. So this will not cause mucosal bleed. Instead of this will cause hemarthrosis, or it can cause muscle bleed or joint bleed. Clear? So again, a good question they have asked in exam. So you have to rule out all the choices. That is very, very important. So this is about hemophilia. This is again a straightforward question. So let's see this question. A patient who had vomiting, no proper dietary intake for 4 weeks. He is not taking good diet. He has treated aggressively. This is the biggest hint in the question. Aggressively treatment with IV fluid. Which IV fluid? Normal saline. So this is the hint that MCQ is giving you. Following which patient developed quadriplegia and became mute. So if you remember, understand this. This is a case. If I say diagnosis of this condition, we call this central pontine myelinolysis. Central pontine myelinolysis, and this is a condition that occur due to a rapid correction of hyponatremia. Rapid correction of hyponatremia. So patient can develop central pontine myelinolysis, that is due to rapid correction. So let us see this. It is due to hypernatremia, no. Inadequate fluid restriction, no. Due to slow correction, no. This is due to rapid correction of hyponatremia. So you know there is a reaccumulation of osmolyte, so that initially patient will develop ODS. ODS is osmotic demyelination syndrome. then this can progress to form central pontine myelolysis, and this is due to rapid correction of hyponatremia. We consider this as a disease of a demyelination in the brain. So we call this a part of demyelinating CNS disease that is seen due to rapid correction. So answer for this question will be A. So diagnosis is central pontine myelolysis. If you remember, like I told you, whenever you try to correct these things, so suppose this is a patient. When you see the patient with central pontine myelolysis, what you can notice, there will be paralysis of all muscle. There will be paralysis of all muscle. There will be paralysis of all muscle except your ocular muscle. So this is like except eye muscle, all body is having paralysis. So patient is developing quadriplegia, right? So this is like somebody is putting you inside the wall, right? So this is what we call, there is paralysis of all muscle. So this is like bricks. So all muscles are paralyzed. There is quadriplegia except ocular muscle. This is what we call this locked in syndrome. Locked in syndrome. So patient can develop quadriplegia, and this quadriplegia where we see in central pontine myelolysis. So answer for this question will be A. Okay, coming to next question, which of the following can differentiate co-infection from superinfection? So like this is again easy question. So let me first tell you something. Suppose you are having a patient who is having co-infection and a patient who is having superinfection. Co-infection means both together. Co-infection means B and D infection together. Both together. So I can say the patient will have B means hepatitis B. So hepatitis B surface antigen should be positive. Then both are together, both are occurring together, both are acute condition. So acute condition of hepatitis B we write like this: IgM anti-HBC antibody. This is positive. And I can say acute condition of hepatitis D, you can see here, this is how we write like this: IgM anti-HDV antibody. This is positive. Now in superinfection you will see first there is infection with B. First infection with hepatitis B. Then immunity is weak. Later on this infection is due to hepatitis D. So first B, later D. So when first is B, so it is B for many weeks or many months, so it means B is becoming chronic. So if I say chronic hepatitis B, how we write? HBs antigen positive and IgG anti-HBC antibody positive. So this is chronic hepatitis B, but later on it is D. Later on D means later it is infected. There is an opportunistic infection by hepatitis D. So D is acute. So this B is now chronic and D is now acute. Here I can say both acute. Both acute. So this will be chronic acute D. We'll write the same way like IgM anti-HDV antibody positive. The same thing I have discussed. You can see B plus D together. Here first B then D. So you can see both acute. You can see here both. This is chronic followed by acute. So how we can differentiate? You can see, let's see the option now. Viral copies can't differentiate because both may have huge number of viral copies. Viral copies can't differentiate. If you see anti-HDV, so hepatitis D is acute in both. You can see hepatitis D is acute in both. So this also can't differentiate. Now if you see anti-HBC IgG, this is seen where? This is seen in cases of chronic B, and this is we see in cases of acute B. Chronic B, and I can say this we see where? In cases of acute B. So how we can differentiate? We can differentiate this by You can see clearly, question is how you differentiate superinfection from co-infection. So superinfection is the one we have to differentiate. So in superinfection, what we see? In superinfection, we see IgG anti-HBC. This is the one thing that we use to differentiate. So by this, understand this, superinfection we can differentiate easily by anti-HBC IgG antibody. Simple. Okay, next MCQ, scorpion bite. The patient is having scorpion bite with bilateral lower lobe fluid accumulation. How you will treat? So let us see this question. Like you can see the patient can have scorpion bite or a cases of snake bite, scorpion bite. So what we need is we need envenomation. So a scorpion bite, how we treat? So what is the role? So now understand, ivabradine will have role. There is lower lobe fluid accumulation. Ivabradine is the drug that is acting on a funny current. This is used to provide bradycardia. This will control the heart rate. That's it. Same is with metoprolol. So metoprolol, what it will do? Metoprolol will do the same thing. This will control the heart rate. If patient is having tachycardia, this can control. Now we are confused between two options. First is furosemide and second is prazosin. This prazosin, I can say this is alpha 1, selective alpha 1 blocker. Selective alpha 1 blocker, and that is the drug which is having good efficacy in treatment of scorpion bite. So this is the answer. Prazosin is something that we use. So don't think like there's fluid accumulation, so we need to give diuretics. Furosemide have we can use in if there is excessive fluid accumulation. Otherwise, there is no role of using furosemide in this patient. So I repeat, you can see scorpion bite. How you will manage scorpion bite? We can manage by prazosin, which is a selective alpha 1 blocker. Which is selective alpha 1 blocker. This you can see a child with cyanotic spells. So they are asking you cyanotic heart disease. So all cyanotic are given the option. So let us see this configuration. This you can see a typical boot shape heart. So the answer for this question is tetralogy of Fallot. You can see boot shape heart. Look at the screen carefully. Second alphabet is O. Second alphabet is O. In TEGA, what you will see in X-ray, you will see egg on string appearance. Egg on string appearance. Again, see this carefully. Second alphabet is G. Second alphabet is G. Egg on string appearance. And if I talk about TAPVC, you will see the patient will have figure of 8 appearance. Figure of 8, or we call this snowman heart. Snowman heart. Epstein anomaly can produce a box shape heart. So just try to understand this. If you count the numbers 1, 2, 3, 4, 5, count the number of 8, 1, 2, spelling is 8, 1, 2, 3, 4, 5. So both have 8 alphabet. So you can remember this in a simple way. The main hint in this question will be the X-ray itself. So it's very, very important hint. Coming to next MCQ, you can see 60-year-old with known case of MI. So first thing you can see that there is age itself. So you can see the age of patient. Age is 60-year-old. Then there is known case of MI. There is diabetes. So like in Harrison, we can see a statement, a line, that is a term we use, atherosclerotic cardiovascular disease. This is like atherosclerotic cardiovascular disease. So patient can develop heart disease. So already now patient is having MI. Lab values are LDL. So LDL target should be less than 70. Here value is given 130. HDL is 40. Okay, this is given almost on a normal range. Then we can see triglyceride 270. Which of the following must be in the treatment plan? So what if you want to prevent atherosclerotic cardiovascular disease? So there will be mortality benefit with this drug also. So what we use is we prefer to give high intensity statin. High intensity statin. So here the main target is we need to reduce the LDL. So high intensity statin therapy we give to patient, and this is very effective strategy. This question came in 2019 also. Again, this is a repeat question. So understand this, high intensity statin we give in a patient. The dose for this, what we use, 40 to 80 mg of atorvastatin and 20 to 40 mg of rosuvastatin. 20 to 40 mg of rosuvastatin, right? So understand this. So this is what you should remember. HDL is normal, so we have like nicotinic acid we can use to raise the HDL, but that is not given. Fenofibrate is not the answer because our goal is to reduce the LDL. So fenofibrate I'm ruling out. Rosuva 10 mg is not the dose. The dose is atorva 40 to 80. So answer for this question is atorvastatin 80 mg. Atorvastatin 80 mg. Clear? Okay, which structure gave rise to hemibellismus? This question again last year this was asked in NEET PG exam. This time they have asked in AIMS exam, INI-CET exam. So that last year it was a bigger question like ballistic movement they have asked. This time they have asked in INI-CET exam. So this is hemibellismus. You know, hemibellismus is due to subthalamic nucleus. So just I'm writing hemibellismus, subthalamus, thalamus, bellismus, simple. If you see there is damage to putamen or I can say globus pallidus. If there is damage to putamen or globus pallidus, then patient will develop something called athetosis. And if there is damage to caudate nucleus, C for caudate, C for chorea, the patient will develop chorea. So these are three movement issues which you can see, and you already know that if there is damage to substantia nigra, then patient can develop Parkinson-like feature. So caudate nucleus chorea. So chorea, this is like a semi-purposeful involuntary movement, dance-like movement that we see. Then athetosis we can see, this is again an involuntary movement. On the other hand, if you see subthalamic nuclear involvement, you can see involuntary but a jerky movement, little forceful movement, that is called hemibellismus. So the answer for this question will be subthalamic nuclear. Okay, this is a repeat question, we have already discussed this, so this is like typed again. So answer for this question will be pleural effusion. Following is least seen in oxcarbazepine versus carbamazepine. So this was like again a standard INI-CET have said there. This is like a line given from Harrison straight away. They have mentioned like it's a line from the table of Harrison. Like oxcarbazepine is superior to carbamazepine in terms of everything, except one thing, like this can cause a fatal rash. So that is the line this they have given. Right. So oxcarbazepine they can produce fatal rash. Otherwise, you can see carbamazepine can produce many other side effects, especially hyponatremia. So I could not get all the options. So what they are asking is which the following is least seen in oxcarbazepine when compared with carbamazepine. So understand this. You can see oxcarbazepine will produce less hyponatremia compared to carbamazepine. So let us see this question. If I give you a summary, like simple thing is oxcarbazepine, this will have less side effect than carbamazepine. Less side effect than carbamazepine, except one thing, that is called rash. Except it cause more rash. Except one thing, that is cause more rash. So some students are saying like answer was which side effect is less seen. Some are asking like it was given which side effect is more seen. So remember always whatever question is given, so you can pick the question. Just remember this line: oxcarbazepine will cause less other side effect compared to carbamazepine, and both are the drugs that we use to treat focal seizure. And both are the drugs that we mainly use to treat focal seizures. So answer for this question, if I say the question is given less seen, following is seen less or more. If it is less seen, then answer will be hyponatremia. But if they are asking like what is more seen, so then my answer will be rash. So you can pick the answer based on what they have asked, because students are giving me different views. Some are telling like it was less given, it was given more. So this is about your oxcarbazepine and carbamazepine. Again, a decent question, a little bit tricky question. Let us see this. The following is correct about hereditary spherocytosis. Hereditary spherocytosis, you know, this is like a RBC cytoskeletal defect. So that is mainly due to defect in protein encheirin. It can also be due to defect in spectrin, or it can be due to defect in band 3 protein. There is one more protein called glycophorin. However, that glycophorin will not participate in any defect. Now, what is the this disease? There are different genetic pattern. The most common pattern will be autosomal dominant. So let us see the option one by one. So I have given you the basic about this disease. The classical feature you will see here will be high MCHC. So first MCQ is what is the correct statement, right? First option is high MCH is pathognomonic. So understand this, high MCH is not pathognomonic. What is pathognomonic? High MCHC. So that is not the answer, it is not correct. What Harrison says, gallstone will develop in the patient by 10 years. So again, this is not a correct option. The answer will be gallstone by 10 year, not 5 year. At least 25% cases have positive family history. That can be, because if you see autosomal dominant condition, if you see the genetic prototype of this condition, so 25% may have. So again, this is like an option which is not given in any textbook, the exact percentage, like how much people will have family history. But considering the mode of pattern, we can say if it's an autosomal dominant, then 25% can have. Splenectomy does not protect against gallstone. So let us see this option. Why we are doing splenectomy? If you do splenectomy, if you remove the spleen, why we are doing this? Because when we remove the spleen, there will be there will be no splenic macrophage, and these splenic macrophage, they will not eat, they will not engulf the RBCs. So by doing splenectomy, what we are doing, we are reducing hemolysis incidence. So hemolysis will decrease. When hemolysis will decrease, ultimately these gallstones which are seen in any hemolytic anemia, these are pigmented gallstone. So less hemolysis means there is less bilirubin. There is less bilirubin means there is less gallstone. So without any doubt, splenectomy will provide protection against gallstone. So again, here it is given not protect. So answer, this is a wrong statement. So answer for this question by ruling out other choices will be 25% may have positive family history. So again, a decent one. Clear? So this is like very important thing. You should rule out. What I noticed, like in all the MCQs, we try to use your brain a lot. We try to rule out other options. So the rule out was the major thing in this exam. A patient misses everything on left side, including drawing petals of flowers, clock numbers on the right side, shaving only right of the body. So you can see this is like a patient who is having a non-dominant parietal lobe lesion or parietal lobe involvement. Because when you see like patient is seeing only one side of the body, this is like what we can see here. He's not knowing like he's having half of the body or not. So this is like a feature which they are giving you hint. What they are asking you is, they're asking you hemi-neglect. And hemi-neglect means this is the feature of non-dominant parietal lobe. If you see frontal lobe, the patient will have aggressive personality. There will be personality change. There will be magnetic gait. If you see temporal lobe, there will be issues in the memory, which is not the answer. The option will be either right or left parietal cortex. This is non-dominant. The answer will be right posterior parietal cortex. Because this is hemi-neglect is a feature of non-dominant parietal lobe. In parietal lobe, I can say dominant type. You can see aphasia, another feature. So this is the answer, right posterior parietal cortex. 23rd is the easy one. This is like high anion gap. Where we see this was like not expected from this type of paper, where you have some so much difficult question, then suddenly like high anion gap. What we write, high anion gap metabolic acidosis, we call this HAGMA, high anion gap. So metabolic alkalosis is not the answer, respiratory is not the answer. So this is high anion gap metabolic acidosis. So basically you will see this either in ketosis or acidotic condition. So answer will be metabolic acidosis. Where you will see this in ketosis condition. We can see this in CKD, right? We can see this in a patient who have lactic acidosis. Right? And you can see sometimes this due to some toxins. Even like in starvation also there can be kidney bodies production, like in DK there can be kidney body production. So we can see high anion gap metabolic acidosis. Simple question in exam. Most specific antibody for SLE, straightforward question. So let me see this anti-centromere antibody. This is seen where? This is seen in A localized form of scleroderma we call this CREST syndrome. We see where in CREST syndrome. Antihistone antibody, this is seen in drug-induced SLE. Drug-induced SLE. And anti-Smith, you can see this here clearly, this is written, and it was written a Q also, this is most specific. Anti-dsDNA is both specific as well as sensitive, so this is most specific. So answer will be B. What about anti-DNAs? Remember, this is specific but not most specific. This also correlate with the disease activity. This also correlate with the disease activity. Means if titer of this antibodies are more, if anti-DNAs titer are more, then patient will have a worse outcome. That is called antibody, which we use to assess the prognosis. That is your anti-dsDNA. So answer for this question will be anti-Smith, most specific antibody. If I talk about most sensitive here, most sensitive antibody will be ANA, anti-nuclear antibody. Anti-nuclear antibody. Hypertensive patient with deranged renal function and hyperkalemia, which drug is responsible? So understand, patient is having hypertension, deranged kidney function, kidney functions are deranged. Kidney functions are drained, which drug is responsible? So patient is having hypertension. Now understand this, and there is hyperkalemia. This is the hint. So they are asking you in simple language which drug can lead to more potassium. Furosemide is a diuretic, so diuretic will cause loss of all the ions. So furosemide can cause hypo thing but not hyper. So this is not the answer. Then like mild to moderate hyperkalemia, I have discussed in my lecture. This can be seen with ACE inhibitors and ARBs. If you take this for long term, then patient can develop mild to moderate, like around, I can say, if you see normal range is 3.5 to 5, so it can cause like about a slight increase like 5.5 or maximum up to 6. So this can occur with ACE inhibitors and ARBs. So out of this, if you see amlodipine, propranolol has nothing to deal with potassium thing. So losartan is an ARB, so losartan can cause hyperkalemia. Okay. 11-year-old boy with tremors and following eye finding. So it was like some people are mentioning it was given icterus is present. So you can see in the eye a huge icterus is there. Now whenever you see a young patient, we should think of genetic diseases, right? And having eye finding and having sister having similar complaint means some genetic history is there. So what is the diagnosis? So some students are telling like KF ring was given, some are saying KF ring was not given. So whether it's given or not given, let us see this option. Hepatitis A, first thing, it's a mild condition. It is an acute hepatitis. It will not cause that severe icterus. And second thing is in hepatitis A, so this is like a fecal-oral route spread is seen. So this will not have similar complaint in sisters. So understand this, hepatitis A is not the answer. Glutaric aciduria is a rare condition. So maybe there are some genetic component here, but remember the more thing here is this is like a condition where you will not see the classical icterus. Huntington disease will have more involvement of your neurological structure. There will be more chorea. So again, by saying this family history, tremors, you can see here, and you can see if KF ring is given, then KF ring, they are more classical for neurological Wilson. Means patient is having tremors because there is secondary Parkinson here, right? In Wilson disease, I told you there can be tremor formation because of secondary Parkinson. The secondary Parkinson, if you do the MRI, what we call this? We call this face of giant panda sign, right? And there are eye finding which can be KF ring or it can be your sunflower cataract. So these hints are sufficient. If it is not sufficient, then remember there is a genetic component, that is sister having similar illness. Huntington disease can also have genetic component, but that is due to I can say anticipation. There is CAG repeat. It is a type of trinucleotide repeat. So if Huntington they are trying to ask, they will give you some history of like generation wise, in father, mother, in father, in son, in grandson, like that kind of history should be given. So by ruling out all these things, you can see the answer for this question will be Wilson disease. This was an easy question. And when I discussed this topic, I told you that this is something they are asking from past 1 year, a hot topic like about the management of stroke. Following is the contraindication. So let us see the indication. Indication of stroke should be like patient should be more than 18 years. This is an classical indication. Patient should present. So this is an indication. So this is an indication. So what are the indication I can say? Patient should be more than 18 years. Right? If you see, the patient should come in less than 4.5 hours. Patient should visit to you in less than 4.5. That 4.5 hours is the window period. Then patient blood pressure should be less than 185 by 110. So they are asking you what is the contraindication. So let us see. Age more than 18 years, do we do? Yes. Sorry, this is typed 3 hours. This is typed years. Presenting within 3 hours, so that is an indication, true. 4.5 hours means that he's coming in 3 hours. That's in the window period, so this is not the answer. BP is more than 185. This is the contraindication. So classical indication should be BP is less than. So if you see here, I have written bleeding. So this is like any bleeding issue, sustained hypertension, BP more than 185, recent history of hemorrhage or trauma, any major surgery or a major GI bleed. So MC edema, most of the students they mark this answer correct. So remember, BP should be less than this. If BP is more, that is an absolute contraindication, right? That's an absolute contraindication for thrombolysis. Repeat question straight away, like came from the notes. Diabetic patient with deranged renal function, which drug can be given? So glimepiride is sulfonylurease. We should stop in CKD patient or in deranged renal function. Vildagliptin, sitagliptin, these are two DPP-4 inhibitors which are not safe. Linagliptin is not having a renal clearance, so this is the drug which don't need renal dose modification. You can see the line here, line to line. This is like linagliptin what we give in CKD patient. So answer for this question will be linagliptin. Okay guys, coming to next question, that is a bedridden patient with aspiration. What is the lung segment involved? So this is like if you see the bedridden patient, so the position of a patient will be supine position. So in supine position, most of the foreign body or aspiration, this will occur in right upper lobe posterior segment. So this is the answer B. Coming to next MCQ, this is again an easy one. So you can see the question, patient has completed lansoprazole, amoxicillin, clarithromycin. So this is like triple therapy. So what we call patient completed dose of triple therapy. So this is a case of peptic ulcer disease. So patient have completed triple therapy for H. pylori. Which investigation is best for success of treatment? So you want to monitor the success. So just try to understand this. If I say for diagnostic purpose, whenever the patient is coming to first time, to make a diagnosis, what we can do, we can either perform upper GI endoscopy, right? What else we can perform? We can also perform, this is like endoscopy will be invasive procedure, or we can take biopsy, but biopsy usually we don't recommend, because biopsy we do whenever we think of a gastric ulcer, because duodenal ulcer, they are not having any chance of malignancy. However, gastric ulcer can sometime convert into malignancy, so biopsy, there is nothing mentioned like that. So upper GI endoscopy, or I can say biopsy with urease test, biopsy we can do, but for biopsy also we need to take sample with the help of endoscope. Then there are several other tests that we can perform. We can perform culture. So for culture also we need sample. For histology we need sample. Histology we need, and this rapid urease test, like it is written, biopsy with rapid urease test. So for all these procedure, what we need is these are for invasive test. So invasive test, any of these invasive tests we can perform on the first visit when we want to make a diagnosis. So here question, they are not asking about the diagnosis. Question they are asking is which test we do so that we want to see whether this H. pylori is eradicated or non-eradicated. For that, what we have, which I am writing now from 5th onwards, these are some non-invasive tests that we can perform. So we can perform serology. So this is like given in a table from Harrison. We can perform serology, we can perform urea breath test, and what else we can perform? We can also perform stool antigen. So if you see, this is a table given in Harrison, that is I am writing here. So these are the tests, like non-invasive test. These are non-invasive tests. So understand this, invasive test, usually we recommend invasive tests whenever we want to diagnose a condition. So in the first visit we can perform this test, but for follow-up, if I talk about follow-up, in follow-up to notice the success of treatment, what we perform these tests. So first let me see the option, then I'll come back to this topic once again. So if you see here, upper GI endoscopy we can do for diagnostic purpose but not for the follow-up. Again, biopsy, this will be invasive, endoscopy is invasive. Now we are left with two choices, serology and C13. This urea breath test, this is using C13. So out of this test, understand this, stool antigen we can perform, but out of this the better is a simple conventional, more convenient test, that will be your urea breath test. This is, I can say, urea breath test is a simple, rapid, convenient test. This I can say, this is a simple, rapid, right, test, rapid and convenient test. This is a test that is commonly used for follow-up. So for follow-up, the most common test, we can also use serology, but better than this is C13 breath test. So that is why the answer for this question will become C. Okay, coming to next question, hemoglobin is 7, low MCV, low MCH, lymphocytosis, high ferritin. So just try to understand this. Whenever you see low MCV, means we talk about microcytic anemia. So all options they have given about microcytic anemia. So let us see, understand this. What are the parameters we need to differentiate this? You can differentiate this based on some parameters, because low MCV, low MCH, you can see in all these anemias, because all these are microcytic hypochromic. So the biggest hint in the question is given lymphocytosis. Lymphocytosis means more lymphocytes. More lymphocytes is a marker for inflammation. So this is one way to remember this. So first remember, there is some sort of inflammation. So I will keep this option in my brain. This could be the answer. So to confirm this, what I can say, I can check the level of ferritin. So understand this, serum ferritin. Ferritin is store form. Then we have serum iron. And what we have TIBC. So just let me draw this table for you so that you can understand how we compare. We compare certain parameters like serum iron, serum ferritin, and then next what we have TIBC, total iron binding capacity. So understand iron deficiency anemia. If I talk about the first one, iron deficiency anemia, this is what you will see here. You will see serum iron is reduced, store form will reduce, and ferritin is inversely proportional to TIBC, so TIBC will increase. If you talk about anemia of chronic disease, here also serum iron is reduced, but chronic inflammation, they will produce hepcidin, macrophage, lymphocytes, they will trap all the iron in the stores, so ferritin will be increased. And TIBC will decrease, because TIBC will be, remember, ferritin is inversely proportional to TIBC, total iron binding capacity. Then if I talk about sideroblastic anemia, here you will see iron overloaded state, so iron is more, ferritin is more, and TIBC will be decreased. So let us solve this question. What you can see there is hemoglobin is less, low MCV, but high ferritin. High ferritin is given. So remember, whenever it's a thalassemia, depending on the type of thalassemia, like it is minor, major, so that will lead to more hemoglobin loss. So you can see hemoglobin is less, so this could be thalassemia major, but there is no such lymphocytosis. There is no high ferritin in thalassemia. High ferritin we will see in only these two conditions. So I am just putting these two conditions. In iron deficiency anemia also you will see low ferritin. High ferritin you will see in sideroblastic anemia and anemia of chronic disease. But you can see the chronic disease means chronic inflammation. Lymphocytosis is the hint. So because of this nature, the answer for this question will be A, O, C, D. Lymphocytosis with the high ferritin, right? If lymphocytes could not have mentioned, or they could have given like history of working in I can say paint industry, or I can say patient taking isoniazid, because of that then answer could be sideroblastic anemia. But here lymphocytosis is the hint that you should understand. Okay, ECG is given, drug not to be used. So let us first see the ECG. This type of ECG was given. So if you see this ECG, what we can see here, you can see there is narrow QRS. QRS is narrow. So first thing, by this ECG, what I can predict is a narrow QRS. And if you see the heart rate, this is irregular. Irregular heart rate means there is irregular RR interval. So QRS is narrow, irregular heart rate, and if you see, then what we see, we will be seeing the P wave. So if you see the P wave, there is QRS. Let me see this QRS, QRST, QRST. So what you can see the ECG. Based on the ECG, what diagnosis you can make? There is no P wave. You can see QRST, but there is no P wave. So there is no P wave. So based on this, we make a diagnosis, that is atrial fibrillation. So patient is having atrial fibrillation. So question is, what drug is not given? So by predicting the ECG, we made the question even more simple. So what drug is not used in AF? So atrial fibrillation, if I talk about this condition, we can use metoprolol. Why metoprolol? This is a beta blocker. So in atrial fibrillation management, we have two strategy. One is called rate control strategy. So we can control the rate. Second is rhythm control strategy. Rate control strategy, these drugs are pretty safer, so we can use class 2 and 4 like your beta blocker and CCB. So in rate control, we can use beta blocker and we can use CCB. So the same thing which I have written here, class 2 and 4, these are safe, so patient can take at home. These are rate control strategy. In class 1 and 3, this is what we call, these are more a little toxic drug. They have more side effects. So class 1 and 3, like 1A, 1B, 1C and class 3. So I can say class 1 and class 3. So 1 nowadays we don't use. Class 3 will include drugs like amiodarone, butylide. So this is like rhythm control, so we can use these drugs. Now let us see, metoprolol is rate control strategy, so we can use. So first thing, we can use rate control strategy, rhythm control strategy. Third thing, what we can use anticoagulant. We can use anticoagulant in the patient. After calculating a score, that is Chatsworth score. Okay, so metoprolol we can use because it's a beta blocker. Diltiazem we can use, that is a CCB. So these are both rate control strategy. If I talk about amiodarone is a rhythm control drug. So this is like we use for pharmacological cardioversion. So we can use amiodarone as a rhythm control strategy. That is a class 3 drug we can use. Adenosine we will not use. Adenosine is used in PSVT, right? And remember, for one reason I can give you for not to use adenosine, because like in 12 to 20% cases, adenosine itself can precipitate AF. So that is why adenosine we should not use. So diagnosis for this condition will be AF, and what drug not to be used, that will be your adenosine. So easy question. By looking at the ECG, you can make a diagnosis. Then you have to remember which drug we should not use. Okay, then what we have a simple question, neurogenic shock result in. So this is like an old repeat question. So neurogenic shock will present with hypotension and bradycardia. Hypotension and bradycardia. So answer for this question will be B. Okay, then we have a question, that is corrected reticulocyte count. Corrected reticulocyte count. So there are multiple formulas available to calculate this. So just I am writing this. Corrected reticulocyte count. So this is not your absolute reticulocyte count or reticulocyte maturation index. This is your reticulocyte production index. This is your correct reticulocyte count. So this we can calculate based on hemoglobin level. We can calculate this based on hemoglobin level, like how we should do the calculation. So you can see this, we calculate like given hemoglobin. The formula to calculate this will be patient's hemoglobin. So what will be the patient's hemoglobin, right? This will be, I can say, how we make a calculation, like whatever reticulocyte number is given. So reticulocytes, this values is given in percentage. This reticulocyte, what we do, we multiply this by patient hemoglobin, how much it is, and divide this by 15. So we will apply this formula. So reticulocyte count is given 9, patient hemoglobin is given I can say 5, divide this by 15. So if you see, this will be 45 divided by 15. So answer will come 3. So answer for this question will be 3. So corrected reticulocyte count, how you calculate? So this is the formula. So answer for this question will be 3. Clear? Okay, next MCQ is perioral numbness and tingling. So perioral numbness or tingling, this is like a hint they are giving you. Tingling sensation, numbness. So patient, this could be a case of tetany. This could be a case of tetany, and tetany we can see where in a patient of hypocalcemia. Tetany we can see in a patient of hypocalcemia. So basically, when I see the first option, vitamin D intoxication, vitamin D intoxication is causing generally a calcification, which we call metastatic calcification. So this will cause hypercalcemia. Vitamin D intoxication will lead to more calcium, not less calcium, right? And tetany is a feature of hypocalcemia. So let's see other options. Hypoparathyroidism can produce low calcium, low PTH, there will be low calcium. Hyperphosphatemia you can see in a patient of CKD, is very rarely you can see in a patient of AKI. So mostly in CKD patient what we see hyperphosphatemia. So then CKD, this can also produce hypocalcemia, there can be low calcium. Then acute pancreatitis, remember this, whenever there is acute pancreatitis, there is a release of enzyme like lipase, amylase. These especially this lipase, they will, with free fatty acid, they will try to chelate the calcium. So this acute pancreatitis can also produce hypocalcemia. So these are the 3 conditions which I am highlighting, where you can see hypocalcemia, but here you cannot see, here it is hypercalcemia, and tetany is a feature of hypocalcemia. So answer for this question by default, by ruling out all the options, will be vitamin D intoxication. On the other hand, you can see vitamin D deficiency can produce hypocalcemia. Is it clear? Vitamin D deficiency can produce hypocalcemia. Okay, next is mitral stenosis. S1 becomes soft in following condition except. So understand this. Whenever we see S1, first third sound will be soft in following conditions. So soft S1, I can say this can occur in obese people, right? Soft S1 you can see in a patient of who is having any type of pericardial effusion, means there is some fluid accumulation. There can be fluid accumulation, there can be soft S1. Then you can see soft S1 heart sound will be soft whenever heart rate is less, that is in bradycardia. Clear? So I could not recall the fourth option. I think there was one option on calcified valve. So when there is more calcium, you cannot see the proper opening of valve. So there is calcification, can also produce soft S1. So just try to understand this question. If you see softening of sound, we call this muffling of sound, you can see in calcified valve. Whenever this MS is associated with AR, so there may be possibility the murmurs and sound of AR will become loud. So that is a possibility. So AR, when it is MS with AR, then maybe you will see more sound on AR. You can see murmur of AR, like diastolic murmur you can see. In heart block, there will be bradycardia. So you can see again, heart block means bradycardia. This will produce softening of sound. So in mild MS, so by ruling out other choice, I can go with the answer. You will not see soft S1. Okay, then there is an ECG given, and what is this ECG suggestive of? So let me zoom this ECG in front of you, and what we can see in this ECG, you can see this is P wave. You can see in the ECG P wave. Then we have QRS, T. After T, there should be P wave, but there is a QRS, right? Then we have P. QRS T. After this there should be P, but there is again a QRS. So there is, you can see every second beat is having a QRS. So this is like ventricles are contracting before the atria. What we call this? We call this premature ventricular contraction, or PVC. So when you see every second rhythm or every second rhythm is a topic, that is called a bi or Gemini rhythm or bigemini. If you see a third rhythm as a premature ventricular contraction, that is called trigemini. This Gemini rhythm, bigemini, trigemini, these are in this ECG. You can see Gemini rhythm. So remember, bigemini, trigemini, these are nothing. These are premature ventricular contraction, and these are seen due to side effect of digoxin. So these are due to side effect of digoxin toxicity. So let's see the options in this. Lack of calibration is not the answer, because they could have mentioned any speed paper, nothing is given. MAT is not the answer, because this is, you can see in this ECG. In MAT, what you will see, more than 3 different type of morphology of P wave. So here we can see P wave, that is a normal P wave, but you can see ectopics beats, that is ventricular ectopics. So MAT is not the answer, because there is no atrial pathology here, it's ventricular disorder. Okay, so ideally you should be confusing in VT or Gemini rhythm. So in VT, what we can see some additional feature. In VT we can see there will be a broad QRS, right? There will be broad QRS, and VT you can see regular RR interval. So you can see RR interval, is it regular? No. So RR interval should be regular. Then in VT you can see some additional features, like there can be some VPC. VPC means there can be a premature beats, there can be VPC, or I can say ectopic beats. There can be some other beats, like there can be fusion beats. In between you may see a normal beat like fusion beat, right? There can be fusion beat, there can be drop beat, there can be VPC, capture beat. So there may be fused beat, then there can be capture beat, means in between you can see normal beat, we call as capture beat. Fusion beat means you can see PQR, they are fused together. So that you will see in VT. So that is why you can see the ECG. See, once again you can see this is like Gemini rhythm. So we can see every second beat is an ectopic beat, that is called Gemini rhythm. So this ventricular bigemini. Okay, then we have an MCQ on grade of dyspnea in a heart patient with SOB, heart patient on with shortness of breath and going to washroom. So whenever we see dyspnea in a person, so understand this, for dyspnea we have 2 types of classification. First is, it could be I can say, just let me write this, dyspnea. For cardiac patient, what we use NYHA. And for respiratory dyspnea, like for COPD patient in respiratory cause, what we use MMRC. So for respiratory dyspnea, what we use MMRC, Modified Medical Research Council. And here what we use NYHA, New York Heart Association. So these are 2 scoring system for dyspnea that we have. So let us see the option, grade of dyspnea in heart patient. So whenever you see this line, heart patient, grade of dyspnea in heart patient, then MMRC is ruled out. Simple. Whenever you see grade of dyspnea in heart patient, MMRC is ruled out. So this is an NYHA. So now you have ruled out 2 choices. So means you have 2 choices, either could be A or B. So let me see. In NYHA we can see we have different grades, like grade 1, grade 2, grade 3, grade 4. So this is, I can say, NYHA grade. So as you all know, like when we go by 1 to 4, what will happen? Dyspnea will increase. So in 1 I can say there is no dyspnea, or only like exertional activity will cause dyspnea. So I can say, right, grade 1 I can say is there will be dyspnea only on exertion, right? Dyspnea only on exertion. This is your grade 1. If I talk about grade 4, and there is no limitation. If I talk about limitation, there is no limitation. So just understand this, like I don't try to mug it up, try to understand this. In grade 1 you will see dyspnea only on heavy exertion, like we all can have, like it's like a normal person. In grade 4 the patient will have dyspnea at rest. in grade 4 there will be dyspnea even at rest, right? And any activity, there is this, I can say, severe limitation of activity. So sometime like patient will have dyspnea even unbuttoning the shirt. So you can see severe, this is like severe limitation of activity. Then if I talk about grade 2 and 3, understand this. In grade 2 you will see the patient will have slight limitation. In grade 2 you will see there will be slight limitation, and grade 3 you will see marked limitation, right? So understand this. If I talk about grade 2, so like suppose a patient is having some heavy bag on his hand, or I can say the patient is having doing some activities, so ordinary activities like running little fast, or after I can say walking for 300-400 meters. So that's ordinary activity. So I can write like this: there is ordinary activity will produce dyspnea. Ordinary activity, right? So there will be ordinary physical activity, like I can say having a bag, or patient is going to classes with a bag, or patient is going to his office, then he is moving for 200-300 meter on road. If you talk about INI-CET 3, here you can see there is dyspnea on less than ordinary activity. Like suppose if I am having dyspnea when I move from here to there, from my bedroom to my washroom, that is very like, and we can go normally. Bathroom or washroom is near to your bed, so that is, I can say, less than ordinary activity. Less than ordinary activity can produce dyspnea. Less than ordinary activity can produce dyspnea. Clear? So I can say this is like a patient can have, if you have to choose the answer by this, remember, NYHA grade 1 they are normal, grade 4 severe, grade 2 there is ordinary activity, and less than, or going to washroom is less than ordinary activity. So answer for this question will be NYHA grade 3. Simple. NYHA grade 3. Is it clear? So like suppose patient is having dyspnea while, suppose they ask you dyspnea while changing the clothes, that is also grade 3. At rest doing nothing, they are having dyspnea, that will be your grade 4. Okay, then this is an easy MCQ, CFTR gene mutation. So you know this is like what we write like this. We write that as F508. That there is a change where mutation. There are more than 1600 mutation. Out of this, remember, there is change in chloride channel. So first you can see tryptophan is not the answer. So let me rule it out. Now you know the answer could be 508. So answer will be deletion of phenylalanine at 508 position. This is your CFTR gene. That is the question on cystic fibrosis. So this is like a first line that we teach in cystic fibrosis. They can also ask you the chromosome number for this condition. So remember, this is a defected chromosome 7, and mode of inheritance is autosomal recessive. In future they can ask you the new drug that we have for this condition is Evacaftor, and N-acetylcysteine otherwise we use. Okay, then see, a 2-year-old child with thalassemia major had multiple transfusion in last 6 months. So first hint is 2-year-old child with thalassemia. So they have given you multiple transfusion in last, which is best to detect iron overload. So this is like a case of, I can say, secondary or acquired type of hemochromatosis. Secondary or acquired type of hemochromatosis. Remember, secondary or acquired type of hemochromatosis. So how we can detect this? What is the test to detect iron overload? Non-transferrin iron, no. So we have to calculate both transferrin as well as non-transferrin iron. Cardiac MRI we can use. It's a new modality of diagnosis, but cardiac MRI will detect only the changes, like patient can develop restrictive cardiomyopathy, patient can develop MI. In that case we can recommend it, otherwise not indicated. So best test will be hepatic iron concentration. We call this hepatic iron index. But remember, this liver iron concentration, for this what we need to do the biopsy. So biopsy generally we recommend for HFE gene mutated form, primary form. Here we know the cause, we already know the cause. The cause is secondary hemochromatosis or acquired form. So we know like it is like an iatrogenic, a doctor is doing multiple transfusions, so this is an iatrogenic cause. We know the cause, so what we do, we can do the simple test, that is serum ferritin. A could be the answer if it could be a question on like how we make a diagnosis of confirmation for I can say primary hemochromatosis, that is due to HFE gene mutation. Okay, then this was the question. Identify the needle given below. So let us see this needle. You can see in the needle what we can see. We can see here this is a guard. This is a non-adjustable guard. So this is a Kleeman needle. Right. So first let me see. Do you know this? Most of the students they mark the answer correct. It is not for liver or pleural biopsy. For bone marrow biopsy, we have Jamshedi needle. And we have Triffin needle. So let us change the spelling of Triffin. I am writing like this, Triffini needle. Jamshedi, Triffini, biopsy. Let me change the spelling. Biopsy is also I from today. So Jamshedi, biopsy, Triffini. Simple. Aspiration, we have two needles. So one is like Klima needle. So A for aspiration. Klima is having A. Klima is ending in A. Second is your Sala needle. Sala is also having double A. So Klima and Sala, how we can differentiate? The Sala needle will be having an adjustable guard. Here you can see the fixed guard. This is your Klima needle. So this Klima needle, Sala needle we use for bone marrow aspiration. Bone marrow aspiration. Simple. Okay, coming to next question, which is you can see simple one. But again, they have made it in a bigger version, which is in primary hypothyroidism. So first just try to understand this. Whenever we talk about hypo or hyperthyroidism, the single best test this single best test will be TSH. Single best test will be TSH, right? But this total T4 and total T3 they have no values, so these are not at all good test. Clear? So in primary hypothyroidism, what we focus on FT4 and FT3. So primary thyroid problem is that's a gland problem. So understand this, FT3 and FT4, that is what you should focus. So free T3 and T4 a gland problem, so this will be low. Because of the feedback you will see TSH level. Pituitary will try to produce more. So primary hypothyroidism, you know the most common cause will be Hashimoto's. So this should be the thing that we can see in the reports. So T3, T4 free form should be low, TSH may be increased. TSH is increased, but remember total form can be normal. So let us see option D first. FT4 high. This is a case of hyperthyroidism. So this can't be hypo. Again, this high options are ruled out. FT4 normal. This could be the answer. Reverse T3 is elevated. RT3, that's reversible form. Then you can see TSH is not normal. So this is again not good. So answer will be A. So remember, TSH is the best form, followed by what we have. We have free forms. So free forms are always better to make a diagnosis than total form. Next MCQ, ankle jerk is exaggerated in which of the following? So you can see this like exaggerated jerks. These are feature of UMN lesion, right? So in UMN, if you talk about UMN, what we can see, you can see there is increase or brisk reflex. You can see increase in tone, right? There is hypertonia. You can see increase in reflex. So there will be brisk reflex or exaggerated reflex. Right, so there can be ankle clonus, that is a type of exaggerated reflex. So you can see tone is increased, reflex, and the type of paralysis that we see in UMN lesion, that will be your spastic paralysis. On the other hand, in I can say lower motor lesion, here you will see hypotonia, you can see areflexia and flaccid type of paralysis. So answer for this question will be UMN lesion. Clear? Am I clear? So understand this. If you see the next question, this is the name, the sign that is elicited. So you can clearly see, let's see this option. All of you I think mark this correct. So without any doubt, this is Babinski sound. Fine. So Babinski, you all guys are knowing. So let me take about the next option. This diadokinesia. This diadokinesia is like you will tell the patient to do the rapid tap. Right? This is a rapid tap. Patient can't do this. This diadokinesia. This we'll see in a patient who is having cerebellar lesion. If you talk about Asterognosis means, suppose I give you this pen, and by closing your eyes you want to identify what it is. So by closing the eyes, I can with feel if I can identify something. Suppose I am closing my eyes, you will give me this remote, so I can say this is something like a remote. This is called asterognosis. So it is like perception. We can make a diagnosis by just feeling the object without visual thing. And then what we can see Wartenberg sign. And understand this? What is this Wartenberg sign? You can see this is sign where you will see, if you see, this is thumb. So there will be involuntary separation. There will be involuntary abduction of the fifth finger, right? So this is, you can see this fifth finger will be little here, and this is what we call Wartenberg sign. This automatically you can see fingers will be like this, right? Involuntary separation. We call this. This is because unopposed action of your extensor digiti minimi. Involuntary abduction of fifth finger, right? This is what we call as Wartenberg sign. Okay, coming to next is a 50-year-old male present with left-sided hemiparesis. Damage to which part of internal capsule cause such manifestation? So understand this, like this is a question which they are asking about the structure that we see in internal capsule. So if I make the structure of this internal capsule, in the internal capsule we have different part. So let me say this is like genu, right? If you see, this will be your anterior limb, and this will be your posterior limb. Now understand this. If you see there is damage to posterior limb, if there is damage to posterior limb, then what we can see? We can see there will be a pure motor type of hemiparesis. Pure motor. Pure motor hemiparesis means like one side will have total motor paralysis. What is that? Is what given in the MCQ. You can see patient is having left-sided hemiparesis, right? And if you see there is damage to the genu part, in this case what we can see the patient can have something called clumsy hand syndrome. Clumsy hand syndrome. Clumsy hand syndrome, right? And if you see the damage damage, like, so in this question if I say what could be the answer, I can say the answer for this question will be posterior limb, right? So this is, remember, pure motor hemiparesis. You can see in the genu, you will see we call this clumsy hand syndrome, or we call it dysarthria. So that is when we see there is damage to the genu part. So the question they are mentioning is left-sided hemiparesis. There is nothing else given. So this is a damage to the posterior limb. Next question, an HIV patient with CD4 count less than 200. So you know most of the dangerous infection they occur when CD4 count is less than 200. Then there is fever, headache, neck rigidity. So diagnosis is meningitis. When they are mentioning HIV, you know, like in HIV, cryptococcus is very common. So CSF biochemistry shows increased mononuclear cells. Sugar is 68. Normal sugar is 2/3 of blood sugar. Protein 50. India ink preparation showed capsulated organism. So this is like the biggest hint in the MCQ. So 2 hint here, India ink and HIV. So the diagnosis for this will be a cryptococcal meningitis. So this is our diagnosis. Now understand this, what they are asking, what is the correct statement? High opening pressure. Now understand the CSF opening pressure is high in almost all meningitis. So in most of the meningitis you can see opening pressure is high. So this is a correct statement. It can be high in bacterial meningitis, it can be in tubercular, in fungal, anywhere. Treatment with LAMB. LAMB is your liposomated amphotericin B and flucytosine. Yes. So what we give, and this is a fungal infection. So in treatment we give LAMB and flucytosine. So this is the treatment of choice. So we give liposomated amphotericin B and flucytosine. MRI is normal in most cases. Suppose let us take this under consideration. Meningitis. Why we do lumbar puncture? Because we do lumbar puncture because most people MRI will not have significant finding. So that is also a correct option. So 1, 2, 3, these are correct, right? So this is like, let me write like this: A, B, C and D. So these 3 are correct. Now CSF cryptococcal antigen level more than 1:32 is good prognostic marker. So when I see this thing, suppose if I am not knowing about something, but you can see when titer are more, when this is given titer are more, antigen titer are more, this will never be a good prognostic marker. Higher the titer of antigen, that will have a bad condition. So this is not true. This is a not true statement. So answer for this question will be A, B and C. So this will be your B. Clear? So answer for this question will be A, B and C. D is not a correct. So they are asking you what is the correct statement. 70-year-old man comes to you with severe headache. In which condition further investigation is needed? So let us see this question. So what they are asking you, like patient is having severe headache. So look at the age of the patient, 70-year-old, and there is severe headache. Where you need further investigate. So let me say first option, worst headache of his life. This could be SAH, subarachnoid hemorrhage. Do we need further investigation? Answer is yes. We can do a CT scan, we can do a lumbar puncture. This need investigation. So this is the answer correct. This answer is correct. Headache with diplopia. This can be seen in stroke patient. This can be seen in many optic neuritis. This can be seen in sometime in patient of multiple sclerosis. So again, this is seen in many neurological condition. Headache with diplopia. So this also need further evaluation. So this can be seen in demyelinating CNS disease. This can be seen in stroke patient. So this need investigation, right? So this is also correct statement. Headache not relieved in 4 hours. So migraine duration normally is 4 to 72 hours. So this is like a migraine. In migraine, do we need further investigation? Answer is no. So this is a false statement, right? First severe headache. First time any person is having severe headache. So this first severe headache could be due to raised ICP due to papilledema. So any first severe headache need further evaluation. So this is also a correct statement. So answer for this question will be 1, 2 and 4. So answer will be 1, 2 and 4. So understand this. So what all headache, remember what are the types of headache that need investigation, that need further evaluation. This is like a table given in Harrison. So what are the types of headache where you need to evaluate the patient, you try to diagnose the cause. So there are many conditions, like this is, I can say first condition in my list will be any headache of sudden onset. Sudden onset. Second thing is, I can say second line which is given in the Harrison is first severe headache. First time any person is having severe headache, this could be due to raised ICP due to papilledema. Then third thing, remember thunderclap headache, or I can say worst headache. Worst headache or thunderclap headache, because this could be due to SAH. Then remember any type of headache which is having vomiting that precede headache. Vomiting that precede headache, because this is mostly seen in hemorrhagic stroke patient, right? Then remember any patient who is having headache, like elderly patient after 55 years, or any headache with unexplained fever. Unexplained fever means there is no infection. So these are some of the examples of headache which should be evaluated. There are some more examples, but you have to remember those important headache. Like sometimes you can say like a headache by lifting or coughing, these are also included. So we call this as dangerous headache. Next MCQ, if I say 65-year-old female, 65-year-old female with history of constipation, menorrhagia, cold intolerance, non-pitting edema, drowsy and develops severe mental alteration. She frequently misses her medication. Pulse is 50, bradycardia, BP is 110/70. What will you suspect? So you can know by looking at the symptom. This is the classical case of hypothyroidism. Patient is missing her medication. Because of this, now she is having a mixed edema, comma. So without any doubt, if I see this question, I will make a diagnosis straight away. There is no heart failure or there is no ketone bodies, nothing like that, no diabetes, no DK. Hashimoto can be a cause which can progress to form mixed edema, comma. So diagnosis is mixed edema, comma. So you can see there is loss of consciousness, hypothermia. Patient can have seizures, and ECG you can see Osborne waves because of hypothermia. Clear? So this is the case of a mixed edema. So how we manage? We give high dose of T4, or sometimes if T4 is not controlled, then we can use T3. Then we need to take care of these all the components, because this is the classical case that they ask in exam. This question, I think this also came in last year NEET PG paper. So this is the case of mixed edema, comma. Okay, female with chronic stable angina came with severe fatigue. Now so this again a pharmacology overlap with medicine question. Severe fatigue during blood sample, you notice brown hue. So two hint here it is given. Two hint. First hint is the MCQ is stable angina. Second is brown hue. So this understand this. This you can see brown hue. This could be due to change in hemoglobin concentration. It could be due to any form of deoxyhemoglobin, right? It could be due to deoxyhemoglobin. Then patient is having chronic stable angina. Then patient should be taking nitrate. So you know this nitrate can convert your oxyhemoglobin to deoxyhemoglobin. So the side effect of nitrate is this: there is a potential risk of methemoglobinemia. So by this you can mark the answer. These other options like sideroblastic anemia, this is generally due to, I can say, lead poisoning or isoniazid toxicity. Then due to some sulfur containing drugs. Carboxyhemoglobin due to carboxy component. So this is like methemoglobinemia because the patient is having stable angina. Okay, the next MCQ, this is like a question which was expected to come, and this came in exam. Duration of prophylaxis in an 11-year-old child with rheumatic fever without carditis or valvular lesion. So understand this. So you are having a patient of rheumatic fever. There is no carditis or there is carditis with carditis. So whenever this word is given, carditis means there is some valvular involvement. So again, this is also a question from the table in Harrison. They have given like till how long you will give prophylaxis. So suppose any person who is not having carditis, there is no carditis, then we give prophylaxis till 5 years. Till 5 years after last attack. Till 5 years after last attack, right? Or when patient reaches 20, or till when patient is 21-year-old, or I can say, or I can say 21 year, when patient reaches 21-year-old. (21st years of age). So patient should take till this 5 year after last attack or till he reach 21 year, whichever is late. So whichever is late. Then I can say if it is carditis is there, right? If carditis is there, then patient should take this till 10 years. 10 years after last attack. 10 years after last attack, or again 21 years, right? 10 year after last attack and 21 year of age. So let's see the question. So this is like an 11-year-old boy with rheumatic fever but no carditis. So this is the case which they are asking. So for how long you can give prophylaxis? So if I see this question, so 11-year age, so the patient, we are not knowing like when is the last attack. So we should give this either 5 year after last attack, or we can see this patient when he reaches 21-year-old. right? So question like if they are mentioning the question for how long you will give prophylaxis, so this is like not a 21 years, this is like patient reaches 21 year, clear? 21-year-old, when he become 21-year-old, so that is here. So in case there is no carditis, then what you will give? You will give this till 5 year. You will give this till 5 year. Or when patient reaches 12 years. So this they are asking duration. Suppose in the MCQs, like if it is mentioned till patient reaches, then answer will be 21-year-old. Is it clear? So why not answer is 21 years? Because 21 years is not the time which you are giving prophylaxis. 21 years is the age when patient reaches. Is it clear? So the question is duration should be 5 years. Suppose if they have mentioned the question like this, till patient reaches 21-year-old, then that could be the more better answer, because the point is whichever is late. Okay, next MCQ. A patient developed claudication while walking 100-meter plane surface, but developed claudication much later on walking uphill. So here you can see there is a claudication. So claudication, but just seeing claudication, many students they have marked the answer thromboangiitis obliterans. So remember this claudication, we have two type of claudication. It could be due to an arterial problem. So either it could be an arterial claudication or any, I can say, vascular problem, or it could be claudication due to neurogenic issues. So understand this. If you see claudication that is arterial claudication, there's a vascular claudication, this will worsen on uphill, whereas neurogenic claudication, this will, you can see the question, patient developed claudication while walking 100-meter plane surface. So he is having more claudication on plane surface. In neurogenic claudication, you will see this will be more in plane surface, right? And arterial claudication will be more when we do uphill. So that is why what we do like we do treadmill test, right? And what we do in treadmill test, we keep on lifting, like what we do treadmill test, or if you move like suppose if you are going into mountains, so we get early fatigue. So if it is like a claudication more on uphill, then that is an arterial cause or vascular cause. If it is more in the plane surface, that is a neurogenic cause. So by you can see the question, you can rule out these two are arterial cause. Fourth option I could not get, so answer for this question is lumbar canal stenosis. That is a neurogenic cause. Coming to next is Haman sign, where we see Haman sign. Understand this Haman sign, this is like a classical simple you have seen here. So this is like when we have pneumomediastinum or subcutaneous emphysema, what patients are having, you can see there is leakage of esophageal content into mediastinum. So whenever you press the patient chest, you will see like eating kurkure or puck sound, or we call this walking in snow with high heeled boot. So that like you are crushing the snow, walking in snow or ice with high heeled boot, that crunch sound we can feel, that is called Haman sign. Again, many students made a mistake, they have think Homan sign. It's not Homan, it is Haman, right? So it's not DVT, it's not, these are again dummy choices. So what we will answer, this will be pneumomediastinum. So where we see Haman sign. So this is like a detailed discussion of all the topic, all the questions of INI-CET exam. Again, paper was a tricky one, but a good paper, more of the conceptual question. So you have to make more good concept to understand the topics. But again, this type of paper give more confidence. So whatever are your results, we are happy with your performance. So if you are having a good results, you already rocked. If you are having poor result, focus on upcoming NEET PG exam. So don't worry, still we have 3 months to prepare for to get a good rank in NEET PG, right? So focus on these things. Remember, these are like recall based question. If you find any added options or a new thing or a new question, you can type in the comment boxes. We will be delighted to answer all of your doubts and more questions. So this is like a detailed discussion of INI-CET recall. Thank you so much. Thank you for listening. Keep working hard. Remember, you can, you will. Bye bye.